Good afternoon. Bob Dorshamry here with my co-chair, Raquel Garcia. Today, we're making available our Rules Committee for BHAAC members and our community of Colorado. So you can hear the transparency and hear some of our questions. It's an opportunity. We want BHAAC members to hear more about the rulemaking and the rulemaking committee and the process, to make sure the lived experience seated body had an opportunity to hear about what's going on with the rules and licensing and all of these things that are changing with the BHA. So today is an unofficial meeting, but official. We did want to make sure that there's transparency with the community. We will not be taking questions from the community today. It is a listening session for Colorado. But you can always ask questions by going to the website on the BHA and submitting through the official process of asking questions of BHAAC if you should have any questions. So there's always the ability to communicate with us. And at some point, we're going to be making it more streamlined with this council as well. That being said, today, if we could go into roll call, that would be fantastic.
Okay. Bob?
Present.
Raquel, I saw you in
Present.
Thank you.
Yeah, I can speak. I just went off camera. Thanks, guys.
Okay. Jesse? Dr. Oberly?
Here.
Nor? Oh, great. Thank you. Is Nor on? I apologize, Dr. Oberly. I talked over you for a second. Okay. Seth? Dr. Kayron Lee? Ash? Jamie Orrick? Cameron? Pasha?
Present.
Raina? Catherine? Ina? Carolyn? Maria? Dr. Rob?
I'm here.
Present.
Oh, great. Thank you. Renee? Selwyn? Andrea? Okay, that was it. Thanks, folks.
Thanks so much. So again, this is an opportunity for BHAAC members to interface with the rulemaking committee, ask questions, and get lived experience feedback. Please welcome our guest on the rulemaking committee. Welcome.
Yeah, I'm going to turn it over. So if our BHA rule team is okay to do introductions, and then you folks are going to do most of the presenting and conversation pieces. So I'll turn it over to Victoria, who can then, you can introduce your team.
Thank you, Angelina, and thank you, BHAAC, for the invitation to meet with you all today. I'm very excited to take a chance to sit down and speak more about this rulemaking process. I do have a very short slide deck, but I thought maybe we could do our introductions first, because I know once you put up slides, sometimes it makes the little video boxes smaller. So, and then I'll also take it down once we're into that discussion portion for the same reason. So to start out, my name is Victoria Lasky. I use the pronouns she, her, and I am the Safety Net Associate Director at the Behavioral Health Administration, which is in our Quality and Standards Division. So that is all things licensing and designation. I will pass it over to Tom.
Thanks for that, Victoria. Tom Miller, he, him, his pronouns. I'm the Division Director of the Quality and Standards Division. So I think Victoria said it, but I just want to give a little bit more detail in terms of what the Quality and Standards team does. So there's a group of folks in addition to Victoria's team that act as licensing managers for substance use disorder licensing, RSSO, which is Recovery Support Services, CSL, controlled substance licensing. So those are the licensing types that we oversee. Then there are a series of designations. The primary amongst those are 2765, which is the statutory site for involuntary care. So we and the Quality and Standards will issue a designation to those facilities that are able to serve people that are on involuntary care, whether that's short or long-term certification or a 72-hour hold. That also includes designation, at least current state, of residential child care facilities, also mental health centers and mental health clinics. So I just wanted to give an overview of the kinds of services that this this division licenses and designates. The last piece is that folks in my division also do all the enforcement work for those facility types, plus take all the complaints of people that are receiving services or anybody that intersects with those facility types. We do investigations for those types of complaints. And then that's in addition to all the work that Victoria and her team are doing to rewrite those current rules and also rules of facility types that the BHA will inherit starting July 1st of 2024. Victoria and her team are going to do some additional detail on that. With that, I'll pass it along to Erica.
Thanks, Tom. My name is Erica Gannett. I use she, her pronouns, and I'm a safety net licensing manager and drafted the safety net approval chapter as well as the care management rules. And I'll pass it over to Olivia.
Hi, everyone. Thanks for being here. Olivia Zern, she, her pronouns, also safety net licensing manager. And I was drafting on the crisis rules, the emergency and involuntary commitment, and 2765 chapters.
That concludes our BHA staff introduction. So I will go ahead and share that brief slide deck now. I am also,
Megan. Megan, should we hand it over to you for an introduction? Yeah.
Sure. No worries. I was just going to let you all get started. Hello, everyone. Good afternoon. Good to see so many of your faces again. Lots of time together today. I am Megan Shelton, she, her, hers, and I am the interim division director for strategy, planning, and engagement at the BHA. And Angelina, I think Angelina already introduced.
And Marina, did you?
Sorry.
No, that's totally okay. My name is Marina Boris. I'm a strategic project manager and an occasional fill-in on BHAAC for staff needs.
And I apologize. Yeah. I would like to, I've invited Yesenia Wilson, who's here. She has just joined the BHA team, our division, our new housing affairs specialist. So I asked her to join so she can listen into the rules session, and she'll be joining BHAAC session tomorrow too, to get to know you folks a little better. So Yesenia, do you want a quick intro?
Sure, thank you. Yesenia Wilson, she, Aya pronouns. I'm so happy to be here, and yes, I will be here tomorrow as well to attend and learn more. And please reach out if you all need anything or would like to talk about how we can help.
Thank you. Now I think it's back to you, Victoria.
Perfect. Thank you. And apologies on that oversight. I wonder if I could get those special permissions so that I can share my screen. I was enjoying not having all the buttons on the bottom, but.
Well, that means Marina needs to share the powers.
Yep, I just did. I thought
All right, you surrendered the magic powers. All right, welcome everyone, and thank you for joining us today.
You are on, Victoria. It's on. It's good.
Excellent. Thank you very much. So we can get started. We start all of our rural stakeholder meetings just grounding in our BHA values of truth, equity, collaboration, community-informed practice, and generational impact. These are values that we take into consideration with every stage of the rule writing process, from drafting to holding stakeholder meetings, incorporating feedback, and we just like to kind of ground ourselves in those values at the beginning of each of these sessions. So we already did some of that introductions. I'm going to again give a very brief kind of overview. I know you all have probably taken a look at that YouTube video that Erica and I put together, and maybe taken a look at some of those person-centered summaries. And I also recognize a few of you from our other stakeholder sessions, specifically our lived experience session. So glad to see some familiar faces and names. And then we will spend most of our time in open discussion to allow you all to ask any questions or provide any feedback on the rules that you have. So as noted, we are recording this session to distribute to anyone not able to be here. And also it would be great if my team could get access to this just to make sure we're capturing any notes to incorporate any feedback that comes out of this session. In addition to our meeting today, you can also send us any questions or feedback in writing. We do have an email inbox and a Google form. Maybe Erica and Olivia at some point today could drop that links in the chat. And you are also welcome to attend any of our remaining rules stakeholder meetings. We have a couple of in-person events left and several virtual events left in these next couple weeks. So and this was largely what was covered in that YouTube video. What are the BHA's provider rules? So in order to provide behavioral health, substance use, and mental health services, many providers are required to have a license or designation, as Tom was describing earlier when he introduced himself. And this license or designation shows that the provider is following our regulations or our rules. And this designation may be required in order to operate their business or receive payment for services. And in cases where they are not following the rules, there may be what's called an adverse action up to and including taking a license away in more serious circumstances. But generally, we are trying to bring providers into compliance and make sure that they are providing those high quality services. The rules are changing now because of some recently passed legislation. So three main buckets of that. There's the behavioral health entity license, which brings substance use and mental health licensing into one license, which is great. We want to encourage providers to be providing a variety of behavioral health services and not make that more challenging. And we need to write rules for that license type for when we take on the authority January 1st of 2024. We also had a law passed with new requirements around providing involuntary services, as Tom described. A large part of that is incorporating some new patient rights into that designation. And that also has the January 1st deadline. And finally, there was the law passed for the BHA to create a process to approve what are called essential and comprehensive safety net providers. So we have that safety net provider approval chapter, as Erica mentioned, that she authored. So again, that effective date for all of those rules is January 1st of 2024. We had done a very brief stakeholder engagement process when we had a July 1st of 2023 deadline, very, very tight timeline, and really are excited to have more time to engage with community about these rules, because we find that the more conversations we have like this, the stronger our regulations are for people receiving services as well as the providers. So we have had a full calendar of events in May and June, virtual and in person. Again, appreciated seeing some of you at other sessions. We also are receiving that written comment, and all of these chapters are available for review on our webpage. The reason we have this June 23rd deadline is a critical part of the rulemaking process is we have to have our attorneys look at it, make sure that that is within the rules that we're writing are within our authority and are constitutional. So that legal review with our attorneys begins July 1st. So once we are closing stakeholder feedback for this iteration of the rules, we will be taking a week to incorporate all of that feedback as appropriate before we package it up and send it to our attorneys. And then also part of the rulemaking process is readings at the State Board of Human Services. So we are anticipating having those readings. Essentially, we're going with State Board through the rules, explaining what's in them. And they are the ones who, at the end of the day, have the authority to say these rules are approved or these rules are not approved. So 2 readings there. We have one in September and one in November. We intentionally created that month gap in October so that any feedback we receive at the first reading, we can then have time to take back and make any necessary changes before moving forward. So that was an intentional choice to make sure we have time to do that incorporation of feedback. This is that same information, just a little more colorful, kind of going through that calendar of events. So I won't spend any time on that, but just another way to show that information, and also can make these slides available if that's helpful afterwards. All right, so now the most important part. So I think we are open to, this is going to be guided by BHAAC members today. If there are any topics or questions or feedback that you want to offer, please do so. We also put together a few discussion questions. You know, I think really what we're looking for is what has the experience been like receiving behavioral health services in Colorado? And with that kind of feedback and information, we can think about how to make things better where maybe there have been experiences that were not totally positive. So we put a few questions together. What is most important to you when looking for or receiving behavioral health services? Any barriers that you or a loved one have encountered? And what are providers doing well now? And what could they be doing better? So those were the kind of questions that I teed up. I will also stop sharing my screen again so that we can all see each other for this conversation. And then I will open up the floor for any comments or questions from BHAAC members.
Victoria, do you mind dropping these questions in the chat so that, although we don't see the slide, the questions are there?
Absolutely. Yep. I think that's what I did yesterday and it worked pretty well. So let me stop sharing and I will do that.
Real quick. Hi, it's Bob Dorsheimer. If you could go through the 3 licensed categories again, I think it might frame how we might ask questions. And I don't know what the 3rd licensed category really is exactly. It seems the comprehensive license. So what exactly does a safety net license do? Can you describe them a little bit more? Is that possible?
You want me to jump in? I saw Tom, you also came off mute, but you're welcome.
Erica, do you want to talk safety net and Tom and I can handle the others? I don't know what you were thinking, Tom.
I was thinking that we would do a current state and a future state response to that in terms of what we currently license. But Bob, I think part of your question speaks to the future state because comprehensive is a way we're going to do services starting January 1st. My introductory remarks were about what we currently license. While what we license won't change in terms of our authority, how we do it is going to be different. So I just wanted to say that first before Erica takes over. Erica's probably got a much more simple way of explaining it than I do.
Thank you, Mr. Miller. It was actually from your presentation that I drew my question, so that's very helpful.
Sure, and call me Tom.
All right, Tom.
Thank you. Yeah, I can talk a little bit about the safety net pieces, and then if you have additional questions about the BHE licensing or designation under 2765. I'll pass that back to Victoria. But so the safety net system is this new kind of structure that's being introduced with the creation of the BHA to ensure that we have access across the state to critical behavioral health services, and that in particular priority populations are getting access to those services. When we talk about priority populations, those were defined originally in the bill that created the BHA, and we're generally talking about folks who are uninsured, underinsured, don't have the ability to pay for services, in combination with folks who are experiencing severe mental health diagnoses, be that substance use disorder, mental health disorders of different types. So that is like big picture, the safety net, and really the mission of the safety net as a whole would be to ensure that no individual is turned away from the behavioral health safety net system without access to appropriate care or care coordination. So one of the pieces of this new behavioral health safety net system is also that folks are triaged when they present for services, they're able to not only gain services within behavioral health system, but if it's identified that they're needing services outside the behavioral health system, that those safety net providers are responsible also for connecting folks to those external services, which oftentimes we're thinking about not just, physical health needs that may be evident, but also things like health-related social needs. So housing, employment support, things to address food stability, safety in different settings where those individuals might be, relationships, things like that. So kind of connecting folks to this comprehensive web of services that does exist in like the social services system. When we think of, yes.
Is that an endorsement of the BHE license? Are they two different things?
That's my next piece. Thank you for,
okay, I'm sorry.
for prodding me along in the right direction. Yeah.
And we haven't had an opportunity to have this type of presentation. So we've heard about BOSOs, we've heard about care coordination. So we've kind of gotten things in bits and chunks. So I asked Commissioner Barnes for today to make sure that task force members understood how much is going on and how we can help advise. That's our role, and help share the creation with this. But I just don't know how all three licenses work together. So I could have waited and you would have gotten there. Sorry.
No, thank you for that additional context. So when we think about these safety net provider types, they're a little bit different than BHEs. So at times, a provider may be both a BHE and an essential or comprehensive provider, but it doesn't have to be that way. And I'll provide some examples. So first I want to just say, so what is an essential behavioral health safety net provider? It's a provider that's opting to become part of this safety net system. It's considered an approval, not a license or a designation like we've talked about in the past. So it's an approval, and it will be for essential providers, they'll be meeting these requirements of the safety net system and providing at least one of kind of the safety net services. So that's outpatient, residential, withdrawal management, crisis, kind of that full spectrum of services. Then we have our comprehensive community behavioral health providers. Again, it's an approval. Sometimes that's an approval of a licensed entity, but not always. And that approval is for a comprehensive provider. Again, they're meeting those requirements of the safety net system, and they're providing all of the following services, which would be emergency and crisis, outpatient, high intensity outpatient, which is like our IOP and PHP programs, outreach, education and engagement, care management, recovery supports, and competency restoration. Sorry, had to think through all those. So they, when they're approved, part of that approval is that they are either directly or through formal agreement, so kind of like a contracted relationship, as an entity providing for all of those services. So oftentimes that will be an entity that is licensed as a BHE when we think of something like a current state community mental health center that might become a comprehensive provider. They'll be both licensed and designated, but in some cases it might be an entity that forms kind of a partnership and like to ensure that all of those services are being provided under this approved comprehensive entity. Does that help? I don't see Bob coming back off mute. So Renee, you're welcome to jump in if you'd like.
I have a question, if that's okay. How do providers become safety net providers?
Oh, can you hold on a second? I think Renee was able to unmute finally.
Oh, great.
Sorry, I finally got unmuted. It had to have me. I had to say, got it for the thing saying it's recording. So my question is, with this, with the different the safety net and the whole bit, how does this affect veterans? Are they going to be go to regular hospital, whatever, and then go, oh, you're going to go to the VA? Or can they say, no, I want the BHA to serve me because the VA is going to screw me up?
Would you be able to speak to that at all? I'm not sure that I know the full answer there.
Thought would be that a veterans hospital could apply to be a safety net provider with the BHA. So if that doesn't necessarily answer, I would say perhaps some of the issue may lie in terms of thinking about this from how do these rules apply to a provider? Because our statutory responsibility is to license, approve, and designate providers. Now, while we have first and foremost in our minds and in our hearts the services that individuals receive, our authority is really about those particular provider agencies. So if a veteran needs services and seeks that from a hospital designed to serve veterans, that hospital could benefit from being involved in a safety net by applying to be a safety net provider with us. Now, we've anticipated that some of those provider agencies can get a facility license. So for instance, a veterans hospital would be licensed by the Colorado Department of Public Health and Environment, and that we can predicate our approval on that particular VA hospital license from CDPHE. So I realize that's a complicated answer, but I think it's a complete answer in terms of how we bring those other facility types into our safety net system.
So just a follow-up question with that. With say a VA hospital says, yes, I want to become a safety net, will they have whose standards do they have to go by? Yours?
They will still be licensed as a VA hospital, so they have to follow CDPHEs. But yes, if we approve them as a safety net provider, and I see no reason that we wouldn't, they would also have to follow the standards for the essential service that we require. Now, I don't think that's a huge barrier, so we believe that there's not a tremendous amount of provider burden there. Also, because it's an opt-in type service, and we want to incentivize that, those services come with an enhanced payment to do those types of safety net services from healthcare policy and financing. And we've talked a lot with the folks at HICPUF to make sure our rules line up with their enhanced funding mechanisms.
Okay, thank you.
Thank you, Renee. I think we had Tina, and then I think Rob had his hand up.
So I was just curious as to how providers become a safety net provider. And are you going to have like community mental health centers still and clinics? I have a little bit of confusion with that.
That's an outstanding question. Erica, do you want to do that?
I can, yeah. So in terms of how they will apply in rule, we've outlined that application and approval process. So it will operate fairly similarly to how someone applies today to obtain a substance use disorder license or future state of BHE license. So they'll kind of indicate that to us that they would like to obtain approval. We will request, certain documentation along with that, and then we will review, similar to the way we do to issue a license, to ensure that they're in compliance with the standard that they need to be following. So we would look at, are they set up to meet the requirements of the safety net system? Are they set up to provide the specific service that they're going to be providing as either essential or comprehensive provider, and then we would provide that approval. And all of those kind of enforcement activities, so investigations, provisional licenses, some of those things that exist on the licensing side will also exist in the approval process. And so if a provider isn't quite there, we can issue a provisional approval and kind of help them to get to that full compliance to issue that full approval. So that all exists in the rules for Chapter 3 and is really similar to what exists current state with the licensing rules. In terms of the community clinic and community mental health centers and those pieces, it's hopefully getting simplified down a little bit. And Tom, if I say anything wrong, jump in. But there won't be like community mental health centers, future state. Those providers will if they choose, opt into the safety net system as either essential or comprehensive providers and will be approved as such. And in terms of clinics, many of those clinics that were formerly designated by OBH, now BHA, will actually become BHEs and will be licensed separate from the safety net piece, though they could opt in also as an essential provider.
So I will preface it with, I just changed jobs from community mental health to a private provider. So I'm learning all of these new things. And it's just happened in the less than 2 weeks. So I'm just learning lots of new stuff. In trying to get a new peer program going and putting in all the groundwork and everything for that, I ran into some stuff and I don't remember where I read it, but in reading all the rules and I saw something about there being something coming up possibly for a 50% supervision thing for licensed staff. And I had some questions about that, because trying to have that level of people with licensure when we're trying to build our number of licensed and credentialed and people providing services in the state of Colorado, it seems like a very high number, especially when we have all of our licensed people providing supervision for all of our like LPCCs and all of that. So it seemed like a unbalanced number to me. I didn't know if there's more information on that. It seemed kind of like where the CAC system kind of came in and knocked out a whole bunch of things. So I just had some concerns with that.
Well, I have some great news. And that is, so just a little bit of background on what I know exactly what you're referring to, that 50% staffing ratio. So just a little bit of history, and then I'll give you the good news. So this had come from our licensing rules for substance use disorder providers that had been a standing rule for them. And with this behavioral health entity license, we are bringing together mental health and substance use. So in an early draft of rules, we proposed to continue that ratio for all behavioral health entities. And we heard loud and clear from the provider community in Colorado exactly the concerns that you raised, that was really not a feasible requirement. And so we went back to the drawing board. Mel Tyler on my team did a lot of hard work to create a supervision requirement to replace the ratio requirement. And I'm happy to, I don't know the citation off the top of my head, but I'd be happy to direct you to that alternative that we've proposed, because we absolutely heard that and took that to heart and went back to the drawing board to see what would make sense to make sure that, that appropriate supervision is in place and that, services are high quality and not impose what may be an arbitrary ratio.
Perfect. Thank you. And I would love to have that.
Absolutely. I will, in just a moment, I will find you the link in the citation, and also just want to say that I think that's a great example of, I said earlier that these kinds of conversations help make our rules better. And that was a very specific example of, we proposed something, we heard the feedback, and we took action on that. So yeah, I will find that for you right now.
Thanks, Victoria. I think Rob had his hand up at some point.
Hi. So one of the questions I have is, I keep hearing hic puff, hic puff, hic puff, and it does feel like Medicaid is driving a lot of the changes, which I understand it felt like they were driving the changes with the CAC system, which just depleted our workforce. And so one of the questions I have is, and I know we're not sure about what the BHAAC system is going to look like, but it really feels like even just with this shift with Department of Corrections, with probation, with parole, there's been a shift where if they don't have Medicaid, like we're not able to work with them. So I'm sorry, I take that back. They're not paying. We're relying right now on our MSOs to catch us up when Medicaid doesn't pay. And I'm wondering, is the funding going to look the same for the BHAAC system? Are they still going to be able to fill the gaps where Medicaid falls short for our indigent clients that don't have Medicaid? And then another question just for the BHA is, right now, as working as a provider, everybody's been knocked off Medicaid now that the COVID emergency has been, the emergency rules that they had put into place. So we have a lot of people in treatment now that need medications that have been knocked off. And so I really do wonder, I keep hearing that we're up to hic puff standards, which I know that is also goes along with the ASAM. And so there's so much confusion about what this is going to look like. And the thing that we keep hearing in the meetings is that this is rule to date. We're doing these rules to date for now, but we know there's so many changes coming up. And just because we've been through this before where these changes just happen so fast. And what it does is it impacts providers, but it also impacts our patients. It impacts our ability to work with them when we're not sure exactly what's going to happen. You know, when the CAC system changed, it was like, boom, overnight, it changed. And we lost a lot of people left our field.
And
so,
it impacts people in recovery in
Right.
ways that creates ripple effects across the board, because there are so many people that were working towards those positions that then can't reach those goals.
Right. Yeah. And no, you're absolutely right. So I'm just asking is, I know HCPF standards, we need a payer, but is that the goal we're trying to meet? Is the BHA striving to meet HCPF standards? Or are they striving to hit, you know, follow, like with HCPF comes the ASAM? I'm just confused because I just keep hearing comparisons to we are working with HCPF to be up to standards. And I don't know if that is 100% the best standard for us to be reaching for, as far as working with our patients and meeting their needs. And then again, are we going to have funding to fill those gaps? And is Department of Justice or is probation and parole, are they going to be funded differently? Are they going to be looped into Medicaid because a lot of them don't have Medicaid, or they have Medicaid limited? And I know there's some changes for offenders as well. So I guess I just have a bunch of questions and concerns on that. That was a lot, sorry.
I think I took the main questions to be, whose standards are there? How does the money fit with what our provider rules are? And then what money flows from the BHA? So first, they are the BHA's rules. And it's not HCPF that's enforcing them or HCPF that's even writing them. But HCPF is the primary payer. The vast majority of the money flows from HCPF. And while there are providers out there that aren't enrolled in Medicaid, I think that's the exception rather than the rule. Part of what we've tried to do, well, we in conjunction with healthcare policy and financing, is expand Medicaid dollars to support this kind of work. So money already does flow to do it, and we're trying to expand that. That is why we want the rules to still work in combination with the funding schemes from HCPF. Now, that's not to be confused with, those are HCPF standards. Again, they are the Behavioral Health Administration's standards. And those in the ASAM in particular is something that we've taken from the national standard and written into our rules. Not only is it helpful to define what quality is for our license, it's also a good way to hang the funding mechanism on it. Now, that being said, we understand that HCPF has as an intermediary the regional accountability entities, or RAIs, that do oversight for the dollars they give. And while I would say that's not our licensing standards, it still is oversight. So we recognize that there's burden on the providers that have to get a license from us and keep a license from us. And also, if they're billing Medicaid, enroll as a Medicaid provider and then adhere to those financial standards. Part of what we want to change with, well, before I go to BASOS, the other part of your very savvy question is, well, what about those providers that aren't enrolled with Medicaid? How do we pay through our intermediaries, the MSOs? While that's not a replacement for Medicaid, we have been able to fill in the gaps. And while we've gotten more money and we want to fill more of those, we still want that to be the non-primary way of paying for these types of services. That's why I'm talking a lot about incentives built into, in particular, safety net rules to get providers enrolled with Medicaid. We hope there's enough money to make it worth their time. And we hope that our rules aren't so burdensome to scare them away from doing that. Now, in an overarching way, we recognize that between HCPF and CDPHE and the BHA and the intermediaries that HCPF and the BHA use, there's a lot of folks that providers have to deal with. And the more time that providers spend dealing with all those primary agencies and intermediaries, the less time they're spending helping people, which is the whole point of all of this, right? So that's really what we're driving at with the BOSOs. We're going to try to combine ASOs and MSOs in a way that makes it less confusing and has less time spent on administration and more time spent coordinating services and dispersing funds. Now, we backed up BOSO implementation to 2025. So how we do that has yet to be decided. We're also continuing conversations with healthcare policy and financing to talk about how we integrate RAISE and BOSOs in a way that doesn't keep them completely separate and forces providers to have to deal with two distinct systems, which may have areas of administrative overlap. So I can't think of a shorter way to say that. I know that's a lot of words to answer your important question.
So the only other thing I would just throw in there, and that's helpful, like to understand, and I know there's a lot going on, and I understand that. One of the other things that I would just maybe throw out there and suggest is that the BHA really, as we move forward, works with educating the RAISE on levels of care and programs. Because, like, just for example, I'll use STIRT as an example. Like, so we have the STIRT program for offenders that Medicaid is covering, and some of us have TC programs. And it's a constant struggle to explain the program to them, the levels of care. And so we've been educating as we've been getting approvals. And we at Crossroads, we pretty much contract with every RAI. So it's just been a lot for us to be educating. And even we have a circle program, which is a 3.7. And some of the RAIs will say, this patient no longer meets criteria for detox, right? And so one of the things is we'll say, you know, we're not a detox, right? Where this is circle 3.7, which is different than, and so it feels like there's been some, not inability, but just some of the RAIs have not been educated, and some of the doctors that are approving and some of the staff, some have been really great, and we've met with them and done trainings, and they've trained us, we've trained them. But some of them haven't been brought up to speed yet on what the programs are and even understanding the different levels of care. So I was just wondering also, as the BHA moves forward, will there be education opportunities for the RAIs and HCPF to catch up with, at least for now, the structure that we have in place?
So gentlemen, I hate having to be this guy. I need to make sure that we are getting to other people's questions in the interest of time. We're at 4:50. I do need to say that when I asked Interim Commissioner Barnes to set this up for us, it's because we were lacking in all of this opportunity. So Dr. Rob, you know, I'll be talking to Megan about bringing this back. We haven't had an opportunity as a task force to go through this. I mean, of course, we could have gone to the listening sessions and helped, but with all of our other work that we're doing, setting up this, it's been a lot. So, Dr. Rob, if you could email the rest of your questions to Tom, I want to make sure that your needs are met today, and I just did not cut you off. Is there anyone else that would like an opportunity to ask a question in the interest of time? And no, Dr. Rob, no problem. You're asking a lot of great questions. We just haven't had the opportunity to get them out there. Anyone else?
I don't know how to present this because I don't talk very much, but when you have all these entities that you're speaking of. And I am a person that with lived experience that has a brain injury. And when you don't have the professionals that work in the entities that you're speaking of that are knowledgeable about brain injury, substance use, and mental health, it becomes very complicated. We have to reach out to other states further away than where we are in a rural situation. And the intolerance of the staff that provide the services becomes more complicated because then we're identified as malingering. We're given diagnoses that don't fit. So I understand that you have all these programs and these things that you speak of, but where do you find the abilities to focus on those people that go into that network and don't provide the service adequately to the community?
Erica, did you want to speak a little bit about how that fits into the safety net regulations?
I certainly can, and then I don't, if you want to follow up on maybe the enforcement pieces. So to speak to some of how we're building in new requirements that speak to some of the experiences that you've shared, and thank you for being here and sharing this with us today. The safety net providers will be held to what we refer to as the no refusal requirements, which are in statute. So they're the law that safety net providers, once approved, are required to serve individuals and cannot refuse to serve individuals based on specific criteria. And some of those criteria that have been added in are specific to like co-occurring diagnosis and disorders. So specifically, we've highlighted like the intersection of TBI, developmental disability, and SUD and or mental health conditions. And so the safety net in particular should be a place moving forward where folks can receive treatment when they present with those co-occurring conditions. And specifically, those providers will have to have staff that have competency in addressing those co-occurring concerns. And so from a rules perspective, that's how we've built that in. I think the second part of your question is, how do we enforce that, and what happens when those providers fail to follow through on those rules that they're being held to? And so I'll let maybe Tom or Victoria speak a little bit to that enforcement process.
I can do it if you like, Victoria. There are very specific criteria built into Chapter 2 draft rules and then our current rule volume. Ultimately, we attempt to bring any provider back into compliance by using lower level adverse measures, whether it be a simple regulatory citation, which requires a plan of action, which basically means what's their plan for coming back to compliance. If that doesn't work, we will issue a probationary license, which is a heightened level of notice, essentially. But skipping forward, if that doesn't solve the problem, we can start what's called a license revocation action, which basically means we issue them a notice of charges, which is a legal action. We've essentially started the litigation at that point, and we will begin to remove that license. Now, the facility in question has the option of appealing that or curing that. Now, while that's the facility approach to licensure, and again, we license, designate, and approve facilities, I heard part of what your question is about is, what about an individual practitioner that's not acting appropriately when providing services within one of those facilities?
Yes.
So, did I get that right?
Yeah.
Great. Now, certainly, while we license a facility, we understand that there are individually licensed practitioners within those facilities. And while the BHA does not have authority over individually licensed practitioners, we will take a complaint about any individually licensed practitioner and coordinate that complaint with the State Department that does have authority. Almost always, it's the Department of Regulatory Agencies. So depending on the comfort level of the complainant, we can either refer that person to Department of Regulatory Agencies and steer them through the complaint process, or we can do some of that on behalf of the individual complainant. We do consider it the BHA's responsibility to do that level of coordination amongst the various state departments. So that's a little bit different than when we existed as the Office of Behavioral Health. So if you're concerned about that, or you know somebody that is, we can talk with you about how to file that with DORA, or you can say, here are the specific facts, and we can do that outreach on your behalf or on the individual's behalf.
Yeah, thank you.
Ms. Martinez raises a very important point, Tom. And my question back to the BHA is technical assistance for providers. So as the rules change and things increase for providers, there needs to be the infrastructure, the education, and the ability to provide these services. That's one of the reasons why I asked for the rules presentation today for the Lived Experience Council. I think we have a major role in supporting the BHA through this process. I think during the rule revisions, because we are trying to establish ourselves as a body, we've gone through some turmoil recently, and we want to get back on track and be doing something. So as chair, I've had multiple emails saying we want to be doing something. And as you can see, this is a very powerful conversation today, and I have 75% of my council present. So Tom, it seems like there's a capacity issue, an education issue, a service issue. How is the BHA going to offer technical assistance and building capacity to make sure that Ms. Martinez has access to care, but a provider isn't held accountable because they applied for this license but don't have the ability always to provide it because we have capacity issues? So how does this council and the BHA work together to discuss the capacity issues that brought us, a majority of us, and our experiences to apply for this council?
Appreciate the question. I think about an answer in two different ways. One is an internal capacity issue, and I'll cover that one first. And then the second, I think about capacity, like i.e. the number of providers that are out there. So with regard to number one, I've complained about the very same thing. Right now, I have licensing managers that have between 100 and 150 agencies assigned to them, which is way too many. The reason I give you that level of specificity is that the way technical assistance happens from the Quality and Standards Division is that if I say to Olivia, here are your 100 facilities, and one of those facilities needs to understand how it follows the rules, they reach out to Olivia. So if I get a question from you and it's about this particular place, I look it up and I say, Olivia, this is your agency, call them and see what their questions are. Well, if Olivia has 150 of those, she doesn't really have much time. So what I've done is I've begged, borrowed, and stolen from money that we have at the BHA to hire more people, plus with support of my fellow division directors, written decision item to get more money from the General Assembly to hire more people. That was approved. So we're adding about 6 additional staff so we can reduce caseloads to provide more and better technical assistance. So not only does that help the facility in question ultimately, the main point is to help the recipient of service. If the facility knows how to do a better job following the rules, we think that equals better support and care for the person on the other end. Now, I think the second half of your question is about, well, how do we get more providers out there? So that's really a whole BHA type answer. But what it means is the BHA needs more money to give to more providers. So we talk about incentivizing providers to join the safety net. We're talking about increasing money that goes to the 6 or so programs that the BHA runs. We're talking about workforce development. So how do we add additional staff to go work in the facilities that we license? So those are things that I don't necessarily run out of quality and standards, but we talk a lot about that at the BHA. It can't be soon enough. These are issues that have unfortunately been a problem for Colorado for decades, and it's why we were at or near the bottom in terms of mental health. We've already made improvements, and we still have so much to do. We think that, unfortunately, these are issues that will take us several more years to solve, but we're on the right track.
In the interest of time, I do want to let the BHA team know that this was one of the personally best presentations, an opportunity for us to interface, with you guys. I think the work that you're doing really interfaces with us significantly. I respectfully ask for you guys to get on our calendar moving forward. I'm going to be asking Angelina, but for those of us that signed up to be a part of this, I think rule revisions and licensing, it affects us as patients and families. And that's why we're here. And all the conversation that we're having today was rich. But I want to make sure that there's adequate time. I wanted to get this before us. There's been so much thrown at this task force in a short period of time. It feels like we're drinking from a fire hose. I'm sure you guys are as well, and I understand that. We are 100% committed to support making the BHA successful. And that's why we came to be seated on this task force. I have one question from a community member, and I guess we need to wrap up. And it's a provider. There was a standing rule with OBH when it came to group size. Some agencies run type of fellowship programs, gender specific, reentry, and group sizes are larger because of experiential therapy. Recently in the rule revisions, Dr. Medlock talked about they're just going to be capped at 12, 12, and 12. No questions asked. In the old OBH days, we could add a therapist and make sure that our consultant, our licensing consultant, knew that we had these fellowship type programs. They're specifically adolescents, they're specifically in gender specific services. The question goes to, is there going to be a waiver for group size based on fellowship type programs? And can we apply for those to make sure that our day treatment type programs don't dissolve?
Yes. Yes, thank you so much for that question. So yes, that is correct that we currently have proposed in rule that cap of 12, to be clear, participants, so not including any facilitators or co-facilitators. And I want to say that, and then I've got two follow-ups. So one is that is still a proposed regulation. So we are receiving feedback on that, and if there's any maybe if it may be appropriate to talk about those more specific cases in the regulations, we are open to that feedback. And also, to your point, Bob, we also would be, and that would be a regulation that we could entertain a waiver for, if that would be an appropriate path. Really with waivers, the most important rule with waivers is we cannot waive any statutory requirements, and that is not a statutory requirement. So I would say that both and there definitely would want to hear more about that feedback, about if that's something that we should take into consideration in the rules themselves. And if maybe that doesn't make sense as the path, then a waiver may be appropriate in that situation, subject to approval by the waiver committee.
I just asked for our reentry, adolescent, and gender-specific services for women and children. I'm happy to discuss this further with the BHA. Been around a long time, but there's fellowship kind of behavioral health programs that do a lot of larger kind of community dinners where we bring families together and have table topics. There's so much more than just 12 people. Anyway, I just want to make sure that that's still flexible, you know, and I think that answered the community. So I look forward to talking to you further about that, Victoria. In the interest of time, are there any last minute questions or departing remarks? I think we just opened up the can that we would love to be a part of supporting you guys with. Is there any asks of the BHA that the advisory council can support you on? Tom, Victoria, I want to make sure it's a two-way street. We're here to be supportive. So is there an ask?
I appreciate that. Not that I can think of right now. I don't think I've done a good job thinking about that. So I will change that.
Thank you. I do know our members are here to support you and want to understand.
I would like to hear more about what's happened with all of the changes in peer everything. I feel like I'm chasing tail. So it's so much. So an update in that area, and like being kept abreast of all of that would be wonderful, if that's possible.
Thank you, Tina.
Thank you.
Other members? Departing words, please.
I just want to say thank you for taking the time to speak with us. The only other thing I would say is this is a great council to talk about the IC process and what's going on with ICs. I think that people, particularly with lived experience, can offer a lot of insight on how that process is going. And it just seems like it's changed over the years and is going to change again probably. So I just think it would be nice to have a voice to talk about how we can improve that process.
Any other task force members? Departing words? BHA colleagues, departing words to your advisory council?
I just want to say I really appreciate the invitation to speak with you all this evening, and appreciate all of the insight and questions, and look forward to working together moving forward. So just gratitude.
Great.
Thank you. I appreciate all your time.